motion to approve the agenda then?
I, Sonia, make that motion.
Okay.
Chris, I can second.
Sonia and Chris, motion to approve the agenda. Any discussion? Any discussion? Okay. All those in favor of the motion signify by saying aye.
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 Aye. Any opposed? Okay, motion carried. All right. First item on the is item number 1, consent agenda. It looks like just the meeting minutes are there from January 21st. Do we have a motion to approve the consent agenda with the meeting minutes included?
This is Desi. I would make that motion.
Desi, okay. Do we have a second?
Second, Steve Owen.
Second by Steve. Any discussion? Any discussion? All those in favor of the motion signify by saying aye.
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 Any opposed? Motion carried. All right, our first item number 2A, TMJ coverage under MetLife Dental. I'll turn it over to whoever's going to speak to that.
I think that's you, Stephanie.
Sorry, I just barely joined. I did not hear the question.
Oh, it's on the TMJ change for the MetLife.
And the question is,
I don't know, Angie had it on the agenda.
oh, it's on the agenda. Oh, okay. So basically, MetLife had indicated that Minnesota requires TMJ to be covered under the dental plan. And because we do have members that are on NDPHIT that live in Minnesota, we are going to add TMJ, not just for the Minnesota members, but for the entirety of the NDPHIT group. It does not change the rates. It does not change anything but adding the benefit. One thing that we are trying to get clarified on that is that we do need to figure out how coordination of benefits will work, because TMJ is also a covered benefit under your medical plan. So those are the pieces that we're still waiting on. But it is going to be a covered benefit. If it is a covered benefit under the medical plan, it might be better for members to try and use the benefit there first, because your dental benefit does have an annual plan maximum. And once you've utilized the benefit under your dental, that benefit is gone. So just, we had to add it because of that compliance side of things. But that is something that will be announced once we've got the document language and rolled out to member groups. Any questions?
Any questions regarding what Stephanie just shared? This is just an update. We don't need any action. Okay.
No action.
Right.
Okay. We'll move on to item 2B, which is the Bakken Area Skills Center.
Yeah, I'll take that one. So a few weeks, probably a month or two ago, they reached out to Angie and asked if they might be able to be considered to be part of NDPHIT. They consist of probably about 10 employees. They work very closely with McKenzie County Public Schools. In fact, McKenzie County Public Schools does their payroll and all their administrative services. So as such, they even though they work closely together, they're still different entities. But given the fact that they do the payroll and the administration and some of the common things like a business manager kind of de facto does, they asked if they can just participate under the McKenzie County Public Schools program. And so we don't see any risk side to them, doing that. They simply would be added as employees or as an entity under McKenzie County Public Schools, and they would do all the administrative side of it, that being McKenzie County Public Schools, in terms of calculating their payroll deductions, submitting their invoicing, and everything that needs to be done to make sure that we're collecting what we need to in terms of premium. And then a communication would be done for those employees, the same as it would be for McKenzie County Public Schools. So that is the ask by them. And so we said, well, we just need to have the board be aware of it and approve it. So that's why we brought it up today.
Just to make sure I understand, it sounds like I guess I'm wondering, do we do a group analysis of that, or they're good with or are they just flowing right under the McKenzie School District?
Yeah, they're a brand new group they actually did sign up on individual policies, or not individual, but a group policy that have metal rates with Blue Cross a little over a year ago. So there's no data on them, or very little data. So we view it as just them adding employees to the existing plan, as opposed to any credibility of any data. So just given the fact that they're so new.
When you say that under the McKenzie County School District group?
Yeah, the same rates basically.
Okay. I just want to make sure we're kind of being, and maybe I'm not quite understanding still, just that we're being, consistent with whenever a group comes on that, that we're, doing what we need to do.
That's the reason why we were looking at, we wanted to see kind of, first of all, if there was any credible history, which there really isn't. So it's almost like you're adding employees under the existing program. And it's because they're doing the administrative functions for them, almost as a blanket process. That's the other reason why, we, as opposed to looking at them individually. So that's the reason why we think that it would be probably, we're confident and comfortable with the idea if they were added as employees or under the structure of McKenzie County Public Schools.
And I think I'll let Jenny, one more thing. I just want to make sure, because you get like we've been talking about, you get one or two people and then all of a sudden it puts your whole group out of whack. So McKenzie School District will then take on the risk of those new folks, basically, is what you're saying.
Yes, exactly.
Okay. All right, Jenny.
Just a question for clarification, Randy, because I don't have a full understanding of how Bakken Area Skills Center came about. My understanding was it was a large, I don't want to say donation, but if you will, from one of the major oil companies to start this. Is it considered a governmental or technically a school? Okay,
that was one of the first things we wanted to check out. Are you funded by a government? And the answer is yes, they are.
Okay.
Yeah.
So just wanted to make sure they fit into that definition of who we are and who our members are.
Yep, that was actually the very first question that we wanted to vet out. And the fact is that they are, and they get their funding that way, and they're structured.
Yeah, the skill centers are very much a traditional CT center, and it utilized the grant that was given out to a lot of centers at that time to build centers. So it wasn't any more unique or different in the way it's funded than any of those new career tech centers that popped up across the state. So,
okay.
And I would think too that would be equivalent to like these special ed units that jump on when, South Central Prairie is close to Napoleon. So I would think we would treat that the same then in this situation.
Yeah, I assume, sounds like Steve's in support, I would guess. So, yeah.
Well, yeah, and I probably will have to abstain from the vote, but I think the idea was they are very much, the school district owns the building, but they are, it is similar to a special education unit. They're a subsidiary of support, we're the parent kind of thing. So we weren't sure how it would be addressed, but I know that they would appreciate the opportunity to get under our umbrella for this.
Okay, Cole.
So just to clarify, I'm fine with being a public entity. I just want to make sure that's in our bylaws, because I can see how our gymnastics program used to be under our insurance, and we switched to NDPHIT. We made them separate, even though they're considered part of us, but we don't have any jurisdiction. But I think of Fargo Park District, they have I think it's the Cass County Social Services they manage on their behalf, which would definitely be a public entity. But when you let one in, well, there's all sorts of aspects that people are going to want to piggyback. So as long as that language is there in the policy for public entity, I think we'd be fine.
Yeah, and one other thing about that is that we did an initial analysis with the attorney when we set up the trust. There is a percentage element, that is allowed, because we had the Association of Counties, and Jenny knows about this. And there's like the separate entity, and so we had to do kind of a formula analysis as well as just making sure that it was compliant with the bylaws. And this clearly falls within the protection of the bylaws. I think that the factor is you can't have more than 1% of an entity of the entire membership that is not within the public sector realm. But we're way under that. I think the group that is part of the Association of Counties has like 15 or 20 individuals. So that was one of the other things that we were checking on, if in fact they did meet the criteria, but this group does.
Okay, so we'll need a approval of this. Somebody want to start with a motion?
I move to approve Bakken Area Skills Center into our NDPHIT health plan under the, I guess I'll call it McKenzie County Public Schools District is how you want it worded. Okay.
I would second that motion, Sonia.
Okay. All right, any further discussion?
No discussion, but I will probably abstain from the vote. I imagine that's appropriate.
And then I guess I do have one discussion item. So would McKenzie County Schools have an agreement with them that specifies that if there's any rate increases due to the school versus the Bakken Skills, that's between them and not NDPHIT?
They would be underwritten as one group.
It's one group. Yeah, they would just be one group. So
From our perspective, they're going to be McKenzie County. They
Yeah.
might be a division under McKenzie County, but everything from an NDPHIT perspective shows them as McKenzie County, which means you're going to have to work out how, from a compliance perspective, how ACA reporting looks and all those other elements. But from our perspective, from an underwriting perspective, your rate is their rate.
yep.
And we are the fiscal agent, so that's all going to be done unified anyway, just to clarify that.
Any further discussion? Any further discussion? Angie, let's do a roll call just because we got some abstaining and stuff. So,
Okay, Mike,
yes.
Cole,
Yes.
Jenny,
Yes.
Desi, yes,
You
Keith,
said yes.
okay, Sonia,
Yes.
Chris,
Yes.
and then Steve's abstaining, and I don't believe Kevin is on. I haven't seen that, so, so 7 yes, 1 abstain, and 1 absent. So motion passes.
Okay. All right, we'll move on to item 3A, which is highlight health.
Yeah, I'm going to include that in the renewal presentation. So I'll get to that as a function of the presentation, and then we'll separately at the end discuss it as to how it works and the structure of it. Fortunately, it's not a cost requirement, but when we get into the detail, we'll show how it can be a facilitator and a help to the trust.
Okay, we'll move on to item 3B, which is the October 2026 renewal.
Yep. So I'll take that and I'll share my screen here. Everybody see that? I'll see if I can go into presentation mode. Hopefully it works. You see that?
Yes.
Okay. So this is there's multiple sections of it that we'll cover as part of the renewal. And first section is just an update on the Digby Health. Everybody is familiar with that program. And we're continuing to finalize and gather the data for their study that they are doing. That's in their process. And this is just a highlight again of how their program operates. But some of the things that they did share recently is just the effectively the engagement level that they're getting, as well as the success. So this kind of demarcation line that they've shown here at 12 is really reflective of the percentage of those individuals who are engaging in their program that are using this, what they call this nutrient density score, that is getting them to a long-term success of individuals changing not just their behavior, but also adopting and incorporating a lot of the principles that they're teaching and using resources. And they'll get into more detail in their study when they release that to us, but they give us updates on this piece of it as well. Then the other component that they shared, they have, I think it's almost close to 700 now that are actually in the program, which is deemed very high as a percentage of adoption. They're using food as the medicine for weight loss, and the clinical improvement in GI conditions has improved with those that have participated. So they have these two pathways, if you would. One is the lifestyle, which is just purely education and engagement. So 86% of the individuals in that path have lost weight, and 56% have lost more than 5%. GLP-1 plus lifestyle, 100% of those individuals have lost weight, and 89% have lost more than 5%. Which is also pretty significant from a lot of metrics and studies that we do with other programs. So their combined process that they do, both with the lifestyle education and the GLP-1, is proving to be pretty successful. And then they just show kind of the clinical outcomes dashboard. And you'll have this as a follow-up if you want to read more of the detail. But what they're really trying to do is focus on gut health and be consistent in their education and adoption. And then, is it sustainable? So that's, again, back to that original slide. If it's over 12, then they're getting sustainability of people changing, not just for short-term, but long-term. This is information actually shared with us about Blue Cross. They looked at our pharmacy data and gave us a report based on the reflection of it's indirectly related to both the GLP-1 management program that Digby is doing, as well as the compounding that is a resource option for the members. But effectively, it's measured one period versus another. So it was the prior period versus the current period. So it's a quarterly report. So in this quarter, it was a 79% decrease in the cost for the weight management GLP-1s, which we knew would be reflected because it moved from, the majority of them moved from the manufacturer to the compounding. So we knew that there was going to be immediate savings on that, and it's proved their data shows it as well. Even in the diabetic category, though, they've seen a reduction in the pharmacy cost. And so just from a kind of summary to that, in 2 quarters, there was about $440,000 that Blue Cross could identify of a cost reduction to the trust. That was the January pool. This is the October pool. And a similar kind of savings and a summary. It was about $490,000 of savings, and that was in the diabetic class and the weight management. So next we'll transition to kind of where we're seeing, even though there are savings from our baseline, and we were forecasting that, if you remember, that there would be the savings. And in fact, we looked at it through October of last year, and there was about $2.2 million of savings to the trust, which is good. So there's been, if we hadn't made those changes, as we mentioned before, there would be a significant additional cost borne by the trust at this point. And if you recall, this is kind of what we changed on the compound option. There's still the manufacturer option, that's the 50-50. And this for obesity. And then there's the compound option. So there is a copay for based on a PPO plan and a high deductible plan under the compound. This is just I showed this mainly because this is a recent report shown by Springbuck, which is one of our vendors we use for reporting. And they gave a 3-year look back at what's going on in GLP-1s. And it is very common, and it is consistent with the data across the United States that the brand drug classification cost have increased significantly over the last 3 years. In this case, 83%. It's being driven by GLP-1 medications because they're considered non-specialty, so they're falling in this class. So Mounjaro, Zepbound, Wegovy, Ozempic, and Jardiance. These are obviously the top 4. And Mounjaro is a diabetic class for GLP-1s. Zepbound is a obesity class. Mounjaro and Zepbound are both of the same ingredient, tirzepatide. Wegovy and Ozempic are semaglutide. Wegovy is the obesity, and Ozempic is the diabetic class for that drug. But overall, again, this is a database with Springbuck, which includes employers across the United States. So it's just a trend that is continuing to drive cost. So here's one of the things that we did. We looked at our data most recently. We saw similar trends, before we made the change almost 1.5 years ago, which has significantly saved the trust the money. However, one of the things that we see now, just again, Mounjaro and Ozempic, this is January of this year. And then if you look at last year altogether, so they're broken out by year, so you can kind of see this. So what we did is that I summarized essentially Mounjaro and Ozempic, because those are diabetic classes, and we really can't do much of that other than if you want to change the cost sharing component. But we already did that. We took it from their value-based drug class at 0 cost share to now it's subject to traditional copays or deductibles when members use it. The obesity class is subject to a 50% cost share and does not apply to the out-of-pocket max. However, if you can see the obesity class drug, as much as that we have tried to change that and use the compound through Digby, it has grown significantly. In fact, our forecast for this year, just as offered through the manufacturer still, is it's about $618,000 on the forecast. And we're still, the cost share to the pool for that, for those drugs is still between $400 and $500, and depending on the drug, it could be as high as $600. So even at a 50% basis, it's still significant. So one of the things that's important to know is that in terms of offering it as an obesity class through the manufacturer, a lot of the employers, in fact, there's probably a little over 50% who still do not offer any obesity GLP-1 medications. We offer it in the structure, the 50% cost share through the manufacturer, or they can get it through the compound at a significantly reduced cost to the member and to the trust. So here, one of the recommendations that we have come up with is to say, if you want obesity medication, you can do it through a GLP-1. You can do it through Digby and the compound, but we should eliminate it through the as an offering by the trust. And just so you know, for comparative purposes, NDPHIT does not offer it as a coverage. So it's not like, we're doing something uniquely different in the market. In fact, a lot of the large employers are doing similar type of strategies. And so if the members want it, they can do it through Digby and the compound. But this saves the trust about 1.7% on the renewal. That's significant. That's just under $600,000. So that is one of our recommendations that we will make. And in fact, at the very end, you can take it up as a vote, because it will be included as a renewal option in terms of how you can see how it will play out. So the next area that I'll get into, and this brings into the Highlight Health conversation. We shared it before, and we'll get into the detail now. But the high cost claimant trend, and I'll get into another section that describes how this is a phenomena that's occurring throughout the United States. It's not just in North Dakota or just with the trust, but the number of members and the dollar value for the cost of high cost claimants is increasing dramatically. And just to give you some context, so on our member change, this is on just in this at the very side here are claims over $100,000. This is the October pool. We had 30 in 2022, 54, 61, 88 this last year of claimants over 100,000. So it's the number of individuals that are increasing plus the cost of those claimants over 100,000. The phenomena are kind of the industry standard of what they refer to this, that is hard for, it's a technical term, but has huge impact on our cost. It's called leverage trend. When we keep to give us kind of the simplified version, we keep our stop loss at 300,000. So any claimant over 300,000 is essentially pushed over to the stop loss reinsurer, which is Blue Cross Blue Shield. And when you have claims that exceed trend, which trend is between 9 and 10%. So let's take a claim at 300,000 and you add 10% to that claim. Now it's 330. We've kept our stop loss at 300. So 100% of that 30,000 goes to the stop loss carrier. That's trend. But when you have the high cost claimants on average go from 300 to 360,000 for a similarly situated population, you've doubled your trend. And 100% of that exposure goes to the stop loss carrier. And they say, well, that's fine. We'll just pass that cost back on to you. So the challenge is, how do you mitigate? And it's happened. If you look at every category, it's claims over 25,000. It's claims, 25 to 50, 50 to 75, and especially those in the $100,000 realm. So when we have this happen, we say, how does healthcare cost increase so dramatically? Well, we already know about pharmacy, which we just went through. But when you continue to have a doubling of your number of individuals, this is a 293% increase in the number of individuals since 2022 in the October pool of claims over 100,000. So the challenge is, how do we mitigate that exposure? Well, what we tried to do, and just so you know a little bit of technical side as well, how insurance carriers contract with the hospitals is they'll set up either a per diem, which is a daily rate based on the admission, or it's a discount from the billed charge. So if you look at Blue Cross, they try to get 40 and 50% discount from the billed charge. But how does a hospital continue to deal with their inflationary cost of getting enough budget to pay their wages and their cost, and then bringing in more technology? They move what's called the charge master. And they just figure out what they need for the next year and they move it up. Okay. And if you're in a small community, it's even harder because you have those are critical access hospitals and they're all over North Dakota. They're the smaller, trying to provide services for the local area. And they're limited on their charge master actually by the federal government as a critical access hospital. But in effect, what they have to do to get the money they need, because they're limited on their reimbursement from Medicaid or Medicare, they shift it to their charge master. So it's not just a 10% increase to their charge master. It could be 15 to 20. Well, who pays that 15 to 20? It's the private sector. They're the ones who have to pay that cost increase. And when they put a charge or if the contract with Blue Cross is at a percentage of the billed charge, you got a 20% increase now to your new contract because that's what they had to move their charge master to. So when we're dealing with this phenomenon and asking the question, why do we continue to see, 8, 10, 15% increases to our healthcare spend? This is the predominance of what's occurring. And between pharmacy and hospital cost and high cost claimants, this is what's driving the highest percentage on a weighted basis. So going back to the question, how can we counterbalance that when we're trying to manage a budget? And that's because this is also what I studied is I looked at, okay, not only do those individuals or the number of individuals over 100 have increased, but a lot of these, when we talk about, our risk pool management strategy, we look at the profile of the demographics, and it's always and consistently and still will be those individuals over the age of 50, and particularly those who are age of 60 and over. So I did a quick study just to say, is this increasing? Well, the answer is yes. We still have individuals that are 60 plus who could be on Medicare that we're still insuring. In fact, this is the October pool for our highest cost claimants. They're still representing not necessarily a lot of individuals, but they're big dollar spend. Like 5 people last year was $1.22 million for the trust of October. So hence we're trying to promote some of the MCG Medicare education, because that is a part of our strategy to help essentially give those individuals an off-ramp, if you would, from our program to something that's legitimate that they can take advantage of. And then I looked at the diagnostic areas that are driving it. It's the same things, but it's increasing. Chronic members are the predominance, and that's correlated to age again and demographics. We had 8 in 2022, 17 in 2023, 24 in 2024, and then 37 this last year. 37 chronic diseased individuals. So aging population, sicker population. And this is October pool. Okay. This is why we get into the Highlight Health conversation. So a few years ago, I was fortunate enough to actually meet this individual. He's an attorney from the state of Washington. And quick story short, his daughter actually had a claim while she was playing volleyball at high school, and got her, took her to the hospital, and took her to the ER and got a $10,000 bill. He said he was not going to pay it at that level, and it ended up being that he got so passionate about it, he took it and created the federal transparency laws that were passed by the Trump administration in the first administration. And effectively what it is, it forces all hospitals to disclose their cost of operations, and actually all providers. When it first got passed, it kind of went from state to state, but it's a federal law. Some states are enforcing it much more aggressively than others. And in just this last year, when the second Trump administration, they kind of reinforced some of the leverage in this transparency rule. And that's what was the genesis of Highlight Health, to take advantage and help employers. So as we all know, where's our cost? It's, in this case, their study shows it's 0.9% of claimants are representing 37% of the employer spend. And that's not inconsistent with what we see in both the October and the January pool. So here was kind of the reinforcement of the law. And that is essentially what they did is they said, first of all, we're going to force all, healthcare facilities to disclose their cost. And we're going to empower the employer to be a fiduciary to decide if they want to cover a high cost claimant at the level that they're being charged. Not that they won't cover it because it's a covered condition and it's under your benefit plan. But do you have to just accept, even if there's an insurance carrier who's already negotiated a rate like Blue Cross does? Well, and I won't go through reading all this detail, but basically these three areas give the power back to employers to enact a process to challenge and reduce those high cost claimants. So there's the gag clause prohibition, there's permissible restrictions to the employer, and now there's an employer empowerment process. What does it take? Well, it takes an audit organization to really look at each claim and determine if it meets certain criteria, and you have to have enforceable language in your plan document. So where it all got started of why we looked at this particular organization is I happen to have another group that had an $800,000 claim. They approached us along with the stop loss carrier and said, hey, we'd like to take a look at this claim. We think it meets the criteria that can be discounted using the federal poverty level charity care component that's associated with that hospital, which happens to be Primary Children's Hospital with Intermountain Healthcare here in Utah. A $100,000 claimant, based on their application of the structure, got discounted down to about $300,000. Even though Intermountain Healthcare is owned by Select Health, they're a carrier, but Regents actually in this case, Blue Cross, was the payer for this particular employer. And even though they had a contract with Intermountain Healthcare for Primary Children's at that $800,000, this law superseded that contract. And that's because the employer is writing the check. And they have fiduciary capacity using this language to enforce these reduced rates. And it's not like the idea is to just say you're not entitled to the money. It's really to say, what does your rule say about what the fair law or the fair reimbursement is for certain parameters of the federal law? And this gets into, again, a lot of detail that I won't get into here, but this is kind of the framework and the structure under ERISA that the employer can adopt in their plan document to use language, to use an auditing firm and the way the auditing firm works, in this case, Highlight Health, essentially they charge, it's 30% of whatever the employer would have, or the carrier would have allowed for that claimant down to what they negotiate it down to. That's how they get paid. Somebody have a question? No. Okay. So they effectively say there's no risk to you, employer, because you would have paid the 800, in this case, doTERRA, they would have paid the $800,000 because that's what Regents Blue Cross said that was their allowable with Intermountain Healthcare. But in this case, they are paying less than that, but part of the cost share to pay the audit firm is they get the 30% of that savings. So, and this is the other thing that's really important that is tied to is the nonprofit status of hospitals have this language already built into their charity component rules. Because they're operating as a non-for-profit, they have to allow these rules to be enforced. And then patients who fall within household incomes that are below the federal poverty level, they become the eligible individuals. Well, I'll show you what that schedule looks like. It's pretty broad. And then if they qualify as their income, then they can use this structure, and the audit firm basically does all the work to make sure that member and the qualifies, and then they enforce the structure or the language of the plan document. So there is a process that they use, and I won't go into all that detail, but it's, the claim identification, they do the technical repricing, and then they'll have the member, if they need to have a conversation with them, if needed, and then they apply the cost reduction. So and they have all kinds of case uses. You'll get a copy of this so you can read some of their, they have several case uses. This is just a couple of them. But the one thing I thought was important that you would want to see is, so I did the analysis. I pulled the data myself to say, okay, which hospitals in North Dakota could actually apply under this situation? You can see CHI St. Alexis, Common Spirit Health, which happens to be here in Utah as well, the free care, and then the discounted care. So we may not get free care, but they'll get discounted care. And in this case, they'll allow up to 400% of the federal poverty level for an individual to qualify either for free care or discounted care, which then they apply that rule and that reduction for the employer. Altru is one of them. Sanford is another. Trinity, Jamestown Regional Medical Center, and Heart of America Medical Center, which is in Rugby. So one of the questions that was asked, which was a fair question, I think Mike asked it when we showed this in a prior meeting, is that going to hurt our small town critical access hospitals? Well, you need to know that that's not where we're seeing the biggest claimants go. They're usually going to Minneapolis. And last year, our one claimant, the $11 million claimant, was in Denver through the Blue Card system. And that was, I'll just make a comment about Blue Card. There is absolutely no transparency between the Blue Card, and this is a Blue Cross issue. It's not, but this organization brought it to light for us because you have a plan state which essentially is paying the benefit, in this case NDPHIT, and then you have the receiving state, in this case it was Colorado, getting $11 million or $8 million when it was negotiated. And because of that structure of the Blue Card system, they have all this lockdown language that, because we asked, give us the data on that $8 million claim. Blue Cross of North Dakota couldn't release it to us. This essentially creates that leverage we need, that all of it's shared, no matter where and who the care is received by. That's important to know. It's not designed to go after the small critical access hospitals that are so important for each of the local communities. And we can put rules of engagement with Highlight Health about that. So again, what does this mean? You can get up to 400% of the poverty level. Well, a family of four earning up to $128,000 are a qualifier. Or if you're a family of four, 64,000, you get free care qualification. And again, you can see the others in a similar situation. So what's important about all this is that I've shared it before, and that's like we're in a chess match all the time. It's like, what's the next move, and what can we do to mitigate, and particularly these high cost claimants. We feel this should be an avenue that, again, the fact that they're operating under a no fee arrangement, but just purely on what they recover, it could be a greatly enhanced benefit for the trust. So I'll stop there because I covered a lot of ground. Any questions on this?
Randy, just a question. Maybe you talk about where does that money come from? So if I'm a free care available up to 200% poverty level,
Yeah.
Where's the money coming from?
So let's say that, let's use the example, my $800,000 claim. The way it works is you don't pay the claim, okay, until it's gone through the audit. So right now, the way that it works, Blue Cross cuts a check and say, hey, we paid this claim for you, you fund us. That's the way it works now. The rules of engagement say you don't pay any claim over $25,000 till we audit it. And if Blue Cross says, well, we don't like that because that's, they'll feel uncomfortable. But the fact is, the new federal law gives the power back to the employers to say, you don't write checks on our account until we authorize you. So they'll calculate what it's worth. So it's not a recovery. It's basically say, we'll pay the allowed amount. And then if there's the 30% of the difference is applied, then there would have to be money sent to the audit firm for what they qualified for. Does that answer that?
Well, I'm just saying, like, if the $800,000 claimant, I'm making 63,000 a year, a family of four, where does that money come from for them? Like,
they effectively, okay, for the family, it doesn't mean anything from a dollar basis other than they're a qualified candidate that is qualified to get the discount for a inpatient stay.
but the discount, so basically it's like, well, they qualify, so we're just going to knock that percentage off.
Yeah, it's not saying,
because they fall in that criteria.
Yep.
Okay.
They met the criteria, so therefore that claim that they were inpatient for or received services for would be the trigger, if you would, for an audit because they met that criteria. Now we're going to do an audit because they met A, B, and C. It's like, okay, now we're ready to go. We're not going to release that claim. And the instruction to Blue Cross is we're going to use the audit firm to validate qualification. And if they're non-qualified, you can go ahead and release the funds. But if they're qualified, then we're going to do the audit and then we'll tell you what the allowable is going to be on it.
Does that delay things for, I'm just talking the end user, right? So like,
Yeah.
This like back and forth, we got to audit it first.
Yep. So there is an element of communication that has to be done to help the member know what's going on. And so that piece of it, Highlight Health has a total communication structure that they're partnering with the employer. In this case, it would be, Angie and our team to communicate because in some individuals, if they don't want to engage with it, that's up to them. Okay. They could say, look, not going to be, not really, this is purely voluntary. Okay. For even the patient to go through, if they're needed any follow-up information. Like on the one individual that we dealt with here in Utah, we actually had, she happened to work in the HR department of the employer. And she said, I'll be more than willing to help. And so there's an element of education. But I think the kind of storyline, if you would, is, look, we're trying to make best use of your funds as well as the employer's funds who are paying these costs. And this is an avenue that can help create the effectiveness and the efficiency to, preserve and to truly act as a fiduciary over the money that's set aside for healthcare. And then the other thing is, even in the whole scheme of things, if you were to see the volume of claims that are, if I go and get a pharmacy, if I'm going in and going to the doctor, or just the normal day types of things, those are never touched because really you have to meet that threshold of claims over $25,000. So it's really, the very few claimants that would be put into that category of an audit. Any other questions about that? Nope. Okay. So I'll this is just kind of their summary slide, as part of their program, but we feel that, it should be something that we investigate to potentially implement in as part of our overall kind of strategy on a go forward basis. So we want to present the board, and again, we talked at the committee level about this service, and unless there's opposition to it, and in fact there's no cost to it, we feel that it could be, you know, a good service for us to incorporate as part of our program.
Yeah, I highly recommend to move forward because with us, with our most of our members being in rural North Dakota, chances are that income threshold with being a teacher and a farmer's wife or whatever it may be, I do think this could help our trust. So highly recommended to move forward.
Is that a motion?
If it's needed.
I think we need a motion for this, don't we, Randy?
Yeah, I would say take a motion on it and then the vote.
I would make that a motion to move forward.
Okay. We have a second?
Kevin's-
Kevin, did I see? Okay, see ya. Got it.
Who did?
Kevin.
Okay, motion a second by Kevin. Further discussion? Further discussion? Any other discussion? Okay, all those in favor of the motion signify by saying aye.
Aye.
I,
Aye.
Aye.
Any opposition? All right, motion carried. We'll move on to renewal action.
Okay.
Hopefully everyone's sitting down.
Yep. So we've covered this before on the, you know, the different plan designs and kind of where the NDPHIT is and the October pool on the planned value. And they're still at the top tier of the gold. It did come slightly down. So if you look at the BR for 2025, it went, you know, we were at platinum at 0.9. There were some that adopted some of those plan changes last year, so it dropped slightly. So it's getting, you know, the top tier of the gold. The one thing, and this goes back to what I just covered, this stands for critical risk index. Essentially, that's the comorbidities and combined high cost claimants of the pool. So although we've dropped down a little bit in our, you know, in our benefit value, this is, you know, we went from 0.81 in 2022 from a risk component of the October pool to we're now at 116%. That is literally the demographic and high cost claimant combined with chronic disease conditions. So that's the reason I show this. It's like, okay, we have a benefit value reference, and then we have critical risk index. So it's the idea, some of these things that we just talked about are going to be really important to help mitigate these number of individuals that are continue to receive these high cost conditions. So, and then we also look at you know, the prior slide was like, it showed the number of claimants at 0.9. We're at 2.8% of our population in the October pool that is accounting for almost 60% of the spend. So it's 126 individuals that cost the trust $22 million. So that's the reason why, again, plan design and RPM strategy is so important. It's like, we have to get more mainstream or mainlined as it relates to the benefit value. And that's why we're doing the standardized plans that we've already agreed to adopt. So to give you some idea, I took the October pool and I ran an analysis in our benefit calculator. To say, okay, let's say that I have a $250 deductible and I have a $500 family dollar deductible, and I have a 90% coinsurance with a $3,000 out of pocket and $6,000 for my family. And that's not too uncommon with what we see in the October pool. That is one of those high tier platinum level coverages. Then I said, okay, let's modify it. we still have the 250 deductible, we still have a $500 family deductible, but now we're going to change it to an 80% coinsurance and a 9,200 out of pocket. What's the cost reduction? Well, it's a 7.4% cost reduction for this example. And if that were to be adopted, one of the other things that we've done and would look at is, do they qualify also maybe to a different tier, at a lower tier, not only for a cost reduction, but to a tier reduction. And that's what we're suggesting is, is a couple things. First of all, it's a reminder, what most of the people look at is this deductible here. The ones who are going to be concerned about the out-of-pocket change are back here. It's the 2%. They're the ones who are going to worry about it. But from a go-forward basis, if you could lower your basis of cost and lower the trend, and that, to the plan, then you have a greater probability of getting collectively, and this is important to know, we'll always have shock loss claims. And one group can have a shock loss claims. But the whole idea is, can we move, the whole pool down, to a benefit level that, is essentially, I'll probably use this other slide to show you this, getting more to the silver gold level in a benefit value structure. And that is getting closer to a 20% cost share at a $9,200 out of pocket, like I just shared. So that's the goal, is to get the majority of the pool at that level, because again, what most people look at is, and what they hits their pocketbook the quickest is the deductible. And if we keep the copays the same, we're not affecting that, but focus on the co-insurance and the out-of-pocket max and making those adjustments. So I use that as an example. Before I get to the medical renewal, I'll just give you a highlight of the MetLife, which is also part of the program. 3% increase on the dental. They did have an increase on the short-term disability, but all of the products are 0. So they all held. Next, I will, before I get into the actual renewal, I will show you what our trend has been up until this year. So the past 6 years, over that 6-year, October has been 5.15, and the October pool up until this year has been 4.72, and that's over the time period, the complete time period. So again, for comparative purposes, one of the things that I'll show, and why we're going to get a trend increase here with October, is that it does show about 13% increased cost over the prior year. And why is this occurring? Well, and why are we having this loss ratio and the structure that we do? There's a couple of things I wanted to highlight on this slide. First of all, our average, if you go down here, our average contract size has decreased. We went, we were consistently 1.98, 1.97, 98, and now we're at 1.91. What that means is dependents are leaving the plan. And there's influence to that. Sometimes it's retirement, but other times it's competing with other options. And sometimes when you get paid cash to go choose another option, that changes our demographic a little bit. So when our average contract size changes, it does influence the ability for us to collect enough premium, particularly if they go from a family rate to a single rate. Couple things that did increase though significantly: stop loss. Going back to what we shared, it went up 23.6% this year, predominantly because, and this is a argument that I had with Blue Cross, they are our high cost claimant, that they paid $8 million on the one claimant last year. That's why one of the biggest influences there. However, what's interesting is that our overall medical cost actually decreased. And that could be a function of, we got some high reimbursements for stop loss, as part of that, but we track this year over year. to see. So we were 710, 832 last year with the high cost claimant, 1242, and we're at 902. What the important thing to know is it's still a trend of an overall increase since 2022. RX, it's held at 4% increase and 0 last year. So there's the GLP-1 was a big influence last year when we made the change. 4% this last year. If you look, remember on the studies that shows that the specialty drugs and brand drugs are trending at a little over 13%, and we are at 4%. So we're beating trend on the pharmacy. But the influence of our average contract size going down, an increase on our high cost claimants for stop loss, even though we're getting some positive, things here, the bottom line is, and the one other thing, when we only collected 6.5% increase to our premium, and we were forecasting a little over 8%. So that has to do with average contract size. Some of the plan design changes that have occurred, is going to, bring that down a little bit. And those are kind of the two phenomena that are working to actually not collect enough money based on our forecast. So we collected only a 6.5%, even though we are forecasting a little over 8%. The bottom line is currently we're operating at 101% loss ratio since October. So we slightly paid out. This is October pool. Fortunately, the January pool is operating better, so it's keeping us below, this 100% loss ratio. But those are just observations, kind of what's going on with our data. And if you can see, even our whole pool, this was the whole pool. Our average contract, our cost went down from 16 to 15 this year. One of the reasons is it went down is that one high cost claim, it kind of pushed it way up in the prior year. So it's now coming to be a little bit more normalized. This is the January pool. For 2 years ago, they went down. But if you look at this last year, they went up. And that does happen. You do just a basis of a year that could occur. This was 2 years ago for October. It went from $11,000 per employee to $17,000. Huge increase. And I will say again, we had a couple of high cost claimants that really drove that up. This year, we went from 17 down to 13, or this past year, I should say. Well, why is this operating, is it going down? This is October, but still, if we look at it from 2 years ago, 11,161, we're still at 13,489, almost 20% higher for October. So that is what is going, and I'll skip over some of these slides just because I covered some of it already, just as to what is going on. So now we're getting just a kind of a reference point to the entire industry. And then I also did kind of an analysis of just what's occurring in the public school systems across the United States. We happen to have a lot of them within Brown & Brown nationally. And so we see what kind of the phenomena that's occurring. And that, the public health insurance premium has increased 20 to 32% over the last 5 years. And it's creating, an unprecedented budgetary pressure. This is across the United States. Family, on the average composite is over 26,000. That's a 20% increase since 2022. And NDPHIT, so I pulled some of their data, they're averaging between, on their bienniums, it's between 15 and 16%. So it's about 8 to 8.5% consistently. Then we looked at the biennium cycle, at NDPHIT, what their cumulative growth was of 32% from 2021 to 2025. And the reason I reference them is because it's a public entity in North Dakota. Blue Cross, in that same time period, they had an 8% average trend increase between 2023 and 26. And last year, they had a 15% increase in their block of business across the board. and again, I shared this before, but this is kind of our trend for NDPHIT. So just to give you some comparison against, again, NDPERS. So this is their single and family rate, 2026, 12,791 and 30,000 for a family. Okay. If we look at our October pool, our family rate is 27,558 composite, and our single rate is 10,664. If you compare that against PERS, significantly less. Even if we look at the January pool, it's still less, both from a composite as well as their tiers. So, and then if we look at all combined groups within NDPHIT as a composite, this is where we're operating. Again, I bring this up for contextual and comparative purposes. It's important to know because we think, well, it's got to be better somewhere else, or this rate is about to be cheaper. And that's why we have found a few groups who said, hey, we're going to go get a different rate or going to shop it. And they do, and they come back to NDPHIT. The next area is to give you a comparison against our book of business that we have as self-funded school districts within the state. This is the high deductible common out-of-pocket for NDPHIT. These are some of the other school districts that offer the high deductible plan with an HSA. That's their out-of-pocket. So NDPHIT common one is $3,400 for an individual, twice that for a family. And then you see Wahpeton, Mandan, Minot, West Fargo, and Dickinson. That's their high deductible. Did they pay an HSA? The only one that pays an HSA for the self-funded groups, the large ones, is actually Minot Public Schools, which we had a call with them yesterday, and we'll see where that goes because they all the other schools have essentially dropped the HSA funding component. We still see some groups in NDPHIT that pay in lieu of cash or a 403B. That's probably where we see it in the smaller districts. We don't see it in these large groups. The PPO out of pocket, NDPHIT is $3,000 on average. This is where everybody else is in the market for the out of pocket max for an individual. Now we get to premium. So in other words, NDPHIT actually has a richer benefit than all the other school districts. And on a cost basis, the pool for October is $14,773. The only one who is lower out of all the schools in the state is West Fargo. They're $13,812. Okay. Again, important for kind of context and comparison, just to see. Now, what's driving this kind of average, all this inflation? These are the main areas. We talked about some of it: prescriptions, labor cost, aging population, hospital, admin, and behavioral health. Those are the top drivers. 2026 is the average inflation in each of those categories. It's significant. And that's what's driving this overall increase at 9.3% in the market. That's the average. So you got some that are, 20 plus, and some that are some that are lower in there. And then I go back to what's occurred since 2017. It's been a 62% overall inflationary basis across the board. It's just that, but the prior slide tells you why it exists and why it will continue, to exist in this inflationary component. And that's why having strategies to combat it, like the Highlight Health, is critical. We're always looking at what's our strategy? What's our structure? When you get institutionalized in a government system, you don't have that flexibility. It's whatever they hand to you in a rate and a letter. And we talked about this before, but these are the areas that we focus on in NDPHIT to really analyze and help mitigate those costs. And again, these are by category of the forecast in the market. This is Siegel report. So specialty drugs are over 12, prescriptions are about 11, and then the medical point of service is at 9.3. I'll skip that. That's, again, just reiterating the same things that I shared before. GLP-1s, of course, are a big driver, which we talked about. So what are the strategies and kind of priorities of employers and their leadership? Cost control, number one. This is a recent survey that actually we did within Brown and Brown to all of our employers across the country. It's two areas. The top two are control healthcare cost and control organizational healthcare costs. This is really, it's kind of in the same category, but they've listed it as kind of their two top priorities: retain and attract the workforce, improve the culture of the health, and increase engagement of their employees. And so it's the big areas of the cost drivers we talked about. It's cancers, cardiometabolic, musculoskeletal, and behavior health. And I won't read all these statistics about it, but you can read it, when you get the deck. So stop loss market, we've already talked about that. What's driving it? The high cost claim activity, gene therapies, leverage trend, explain what that is, especially pharmacy. The shift to the alternative mitigation strategies, I'll just highlight this because we did talk a little bit about it. There are some point of sale pharmacy rebate programs out there that help. Blue Cross does not do one of those, but the transparency law was listed. And so that's why we've got it. I just wanted to highlight that because that's one of the areas we just talked about. Fiduciary duties are intensifying. In other words, when you're acting as a fiduciary, you're making decisions to spend money in the most efficient and effective way. And that's why again, using a transparency leverage is an important reflection of using your fiduciary capacity. Summarize. It's prioritize cost control, mitigate the high cost, and actually AI is going to play a big part of that in the future because we can gather data and information that historically have been very difficult to get. Compliance is another area, and then just integrate the holistic well-being approach. And that's the other thing that we've tried to do within the trust is deploy programs like the on-site screening programs and other things like it, and the Digby program, that we are really trying to touch the individual. I've said it before, and I'll say it again, and that is, in the end, as much as we talk about all this, we're talking about people's lives and about their health and their personal needs. And we can't lose that sensitivity. And I certainly don't. We all have our own story to, that helps us realize that why we value our healthcare and our choices so much. But we also have to be balanced with the responsibility that we have of managing our cost. So our underwriting rate action, I shared it before. If we, in our prior meetings, we were looking at a 12 to 15%. Well, by removing GLP-1s, we're at 13.71. And because it saves us that money that we spoke about before. But it's that we looked at every possible way to adjust our weighting and our structure on the underwriting. But we just have, the past 2 years, particularly where the predominance of our high cost claimants are reflecting in the data that we can't get around. That's the challenge. So that is the renewal forecast for October of 26 through of 27. Now, having said all that, I shared with you one example that, if a group changed their co-insurance, that was actually, I used kind of the entire pool data to calculate that. But if, two changes, that could be changing the co-insurance from a 90-10 to an 80-20 and going to a 9,200 out of pocket. They got a 7.4% relief. Plus, if they got a tiered adjustment, it might be another 2% of reducing the cost increase to whatever whatever theirs would be calculated. So what does that mean? We looked at two spread options. One is 2.25. We'd have 26 groups at 105% loss. Now we've got to remember, on top of the loss, you have IBNR and you have inflation, because we're forecasting cost, if you think about it, with this model all the way till September of 27. So you have to use this inflation. So even though if they're 105% loss ratio, we have to forecast those costs way out there. with those two other components. So we had 26 groups in that category, 11 in the 2, 9 in the 3, and 33 in the lowest category. But the important thing to know is 37% of the groups, or 69% of the, represents almost 70% of the pool cost. So if we didn't have those better operating groups, to get it on a weighted basis to even reduce what we got as an increase, these 37 groups are driving 70% of our spend. And they're in this category, 105 to 366% loss ratio. So effectively, their pool structure on a 2.25 spread is you have 17.16 plus your 1%, so it's really 18. 14.91 plus the 1%, so it's 15.91. And even these are non-wellness rates. You have to add the reserve fund on top of this, and we'll put it in a disclaimer when we send out the deck. 12.66 plus the 1% and 10.41 plus the 1%. And so that's a 2.25 spread. The other option we looked at is a 3.39 spread. And we did it at 3.39 because what we were trying to do is stay for this bottom tier that have loss ratios below 80% to be below 10. So it's 19.96 plus the 1% reserve, 15.57 plus 1, 12.18 plus 1, and 8.79 plus 1. So it's really to kind of come up with the right spread with the rate adjustment so that that we can go forward with kind of calculating those rates, and then how do we adjust when they want to adjust their plan, because we feel like this could be a really good talking point, obviously, for this next year to say this is the chance to probably make some changes in your plan to get more efficient and to get closer to the standardized options. So I'll stop there. Take any questions or any feedback.
Well, this is cool. A lot of information to take in and try to understand correctly, but remind me again the 4 plans that school committee put together. You're saying these groups have not made that transition because we gave them 1 year to make that transition, correct? The
majority of the groups have not made or adopted like a change in their out-of-pocket or their co-insurance. The majority
But we gave them a 12-month notice essentially that says you will be grandfathered into these. Okay. So
well, this renewal cycle, they get to choose whether or not they adopt the new strategies. They'll be moved to a new plan design in 2027 for the schools. So this year it's optional.
So if I got my whatever rate and you're telling me it's going to be whatever 13 or 19%, and I want to go on that plan now, what will that savings be?
It will depend on the plan that they're on and the rate that they're getting. Yeah, it's going to depend on the plan that they're on as compared to the plan that they move to. So every individual group will receive their renewal at the rate that they're in right now in one of those tiers, and then we'll compare it against a plan that they could move to. But it's based on every individual group, where their loss ratio put them, and what plan design they move to versus what plan design they have. Because if they're on a really rich plan and move to a 9,200 out-of-pocket maximum, they might get several percentage points off. But if they're already on a very high out-of-pocket maximum, there's no leverage any longer on those plans because they're capped at what the IRS says that out-of-pocket maximum can be. So there's not as much leverage for them to move. So it's going to depend on every single group on whatever plan that they're on.
So could it be a 1 to 3% decrease on their rates if they did it? Just hypothetical.
Again, it's going to depend on the plan actuarial value that they're on as compared to the plan actuarial value that they move to. So I can't. Yeah,
I can address. So if you go back to if you think about the example I gave, they had a $250 deductible, of 500, $250 for an individual and a $500 deductible for a family. They had a 90% plan co-insurance, and they had a 3,000 out of pocket. Okay, that is the actuarial value of that structure of that plan example. And what I modeled it to is to say, if you changed the school, let's say that was a school district plan, in that model from a 90-10 plan to an 80-20, and you moved your out of pocket from 3,000 to 9,200, the model said, which is what Stephanie's explaining, is because that was the plan example, they would have, in that example, they would have, the modeling showed it would have been a 7.4% reduction to their cost. I mean, to the renewal.
Yeah, I think because I met with the group yesterday, so I, of course, like everybody that's a school district now, is wondering what tier am I in, which is what I found out, and we are in the top tier, which is really unenjoyable. So we're looking at a basically 20% increase, and we've messed with our out of pocket, but not to the extent we're probably in that average, near the average. So, I mean, for us, Cole, like we're gonna see what we can do about that, So if I can, and then that's hard, right? Because I'm gonna have employees that are they're already mad because we increased it, 2 years ago, and then now we're gonna have to really look at some things, but we can't continue to get a 20%, and then it's our largest increase that we've ever received, and I have a hunch it's going to be for a lot of folks, so that's going to give me a reason to move forward on further changes to our plans and plan design. So
It's a little bit frustrating though and I know it is what it is and the numbers don't lie, but I look at all of the proactiveness we have tried in controlling costs and controlling premiums. And so it's just a little disheartening to see where the numbers are falling again this year after really trying to make some steps forward in trying to control our costs, but it is what it is, but it's still hard to see.
I think the problem is that like in the October pool, there hasn't been a lot of movement within their plan designs. I think as we've talked about, January pool has maybe made more movement, which I think we've kind of, at least from anecdotally for me, it's likely because you don't have to negotiate with an entity like we have to, right? So we're going to be slower to adjust, and it's going to be more complicated for us, And so I've cooled down after yesterday at about this time when I got still a little frustrated, but there's going to be a lot of other superintendents that are, of course, have been frustrated for the last couple of years, and they're going to get hit. 26 groups are going to get a pretty significant increase.
To your point, Mike, I can tell you that the other self-funded groups that we work with that I showed you, it wasn't until they reached that same apex of trend that they decided they had to make changes to their plan. And they're operating at a much higher cost, even where NDPHIT is today on the October pool groups. So, if you look at, some like Minot and Dickinson, they're over $19,000 per employee. And even Jamestown, they had to get to that about 3.5 years ago. We just said, you want to continue to get what you're getting, then keep the plan to what you're doing. And then they finally just said, let's just get it all changed.
I think the fear, that, going to standardized plans with the promise that, things will go down, we're going to control the costs. I think the concern would be will it, and for how long will it, control the costs? And you look at that scale of 5-6 years ago, we're at 0% or negative, and we've already got to 20. And then, you kind of make the corrective action, but then it really creeps back really quickly. And so I think that's going to be the concern of some, like, okay, we're going to do the standardized plans now. It's really going to fix things. And people think that's going to be like a long-term fix, but it's going to be an address, but it's still not going to guarantee double-digit increases. And so that's just the world that we have to address. There's no magic pill that's going to solve the problem, it seems like. So I think that's the frustration of who we deal with are going to experience that and say, well, sure, we'll do this now, but in 3 years, are we going to be back here looking at 15% increases again? And then, like Mike said, you fight the battle and then you come out in a couple of years and you're right back where you started. It is a little defeating on that part. I mean, I'm just playing devil's advocate on that. Hopefully the standardized plans are going to be better, but I think we have a lot of people are going to view that as, if it's very short term, then we get a lot of negativity on it. But not that you can do anything about it. You have to do something. But
Yeah, and that's why, Steve, it's not just a plan design change. It's actually implementing programs that we're staying ahead of. It's like multiple things combined with the plan change that is going to give us the ability to create the leverage points to mitigate some of those, particularly again the high cost claimants.
yeah.
Have we had groups who left or said they're going to leave and then come back? Have they found that the rates or the amounts are similar?
Yeah, we've had groups say they're leave and then they go shop it and then they stay.
I think we just gotta, it's kind of like what Steve said. Always our messaging is really important. And so like, we can't guarantee anything, you're going to get that short-term payoff. If like the example you gave, Randy, like if Rugby School District goes in and we do all the things you recommended and we get a 7.4 whatever reduction, that's going to help for 1 year. But if it's random, as $11 million for one person, it could be that year.
Yep.
And so I just think we got to quit. I think we've learned from this being on the trust that we promised too much initially when we gave the rate reduction, and we just there's no promises. Like, this is where you're at, and we're going to do our best to keep premiums low, but in some cases they may not. Next year I'll be on the tier 4, I hope. Maybe not.
I will say that most of the groups that have made the changes are in the lower tiers. Not all of them, but most of them, because we did look at that.
And the other aspect will be the 3% cap on property taxes too. I mean, that's something they're going to throw out at us. Is their tax? This is going up 20%. And I'm only getting a 3% increase. It's going to impact a lot of agencies.
That's what I was just gonna say, is what Cole just said, is as school districts, I think like superintendents and business managers trying to fold out or plan out their budgets, everything's hitting at once, so it's just really hard timing. And also I do think with our rate increases this year, it's gonna entice schools to look at the plan changes now versus waiting until next year, when I think a lot of schools negotiate and then wait to, because I feel like Brown and Brown would have been bombarded next year, but I think with these amounts, it's going to entice the schools to look at changing their plans this year. So I think it'll help in that factor as well. It's just a scary world right now.
Further discussion. I think we've got, from what I understand from Randy, correct me if I'm wrong, but we've got a choice to make over here. Do you want, I think I gotta look at my screen here. A spread, right? The 2% spread or the 3 point whatever spread is what you're looking for.
Yeah, it's either the spread or the 2.25 or the 3.39. And again, the reason that we did this one is we're trying to really help the better performing groups that are helping offset some of the high cost claimants. But anyway, but we came up with the 2, and typically we have had 2 options for a spread consideration.
Then Randy, Does the GLP-1 have to come into that factor as well?
Yeah, we need to, yeah, so that's gotta be one of the votes, is just to say it's only covered through the compound and Digby, and not the 50% basis, for the manufacturer. And we don't necessarily have a lot just because it's expensive. In other words, when we did it the first time, we had in the hundreds. Yeah, we have less than probably 60 or 70 that are on it now.
I think we should talk a little bit about that. I know you kind of touched base on that. There's an impact to the end user, basically, that they don't maybe get as free of a choice over things. It's gonna be dictated. They have to go through the compound, right? Pharmacy.
Yeah, it lowers their cost.
It
Remember,
does.
it's a cost reduction.
But that may not always, if there's a comfort level, like cost is one, right? I mean, Angie, you gave the example of the one person that was like, they had habits of how they wanted to do things, and then we messed with that. They were mad, and then they were okay after they started doing it, right?
Yeah, so it's the comfort level and what they know. And so when they're forced into a change, like this is a little bit different. They had the option to do it, right? But they were against doing it. They didn't want to do it. This is what I know. This is working for me. I don't want to change. And so I just worked with them a little bit more and encouraged, and they ended up making the change and were happy in the end. But it is that roadblock of the communication and how it's rolled out, and the pushback that we will get, and there will be some frustration. I can guarantee that, and there will be pushback on that. So there'd be an education piece for sure on that. And yeah.
How many individuals was that? Did you say?
Yeah, I think I looked at the number, it was fewer than 60 were using it. And it looks like it kind of is an interval. They don't always stay on it, but you have kind of different people using it for a period of time. But it's been consistently in that like 60, I think it got up to 65. But again, when we did the original change, we were in the almost 200. So this is much smaller number we're dealing with.
So does everybody understand that basically that's rolled into these costs? So if we don't accept that change, then your premium rates are going to be higher.
Yeah, it's about 2% higher.
So, I mean, just understand that, I guess.
And again, one piece of context is almost 60% of employers, don't even offer it as an option anyway, or anywhere. So just the fact that there's a inexpensive option available to them and it's I think is positive in terms of its messaging and communication.
Can you go back to the previous slide?
Previous?
Just to see the 2%.
And that's specific for weight loss.
Only, yeah, diabetics doesn't change. Yeah, they'll have Mounjaro and Ozempic still, just like they do now.
So just to differentiate between the slides, correct me if I'm wrong, Randy, it's basically like the 2% is going to be more of like everybody's sort of sharing more of the load, whereas the 3.3% is going to be kind of spreading that out a little more, rewarding those that maybe made plan design changes, maybe not in some cases.
Yep, that's really it. Yep.
Okay. So we're looking for a motion to accept one of these options.
I guess I'm a little concerned, the 3.39. I mean, I know we want to help the bottom tier, but when that top tier is getting close to 20%, that feels like a threshold number that's really difficult. I mean, I think you're getting close to 20%. That's just something in my mind to avoid. I mean, you can say that's by their choice, but I think there's high cost claimants and things that are not their choice. I mean, these districts are not maybe being penalized. It seemed like, well, you're getting penalized because you didn't play ball and make a change. That's not the total story, right? There's also other factors that could put you in that tier. even if you tried to make some good changes. Rugby tried to make some changes there in tier 1. So I don't know about trying to slap the hands too hard of the tier 1. And I don't even know what tier I'm in. I just think maybe that's where the 2.25 maybe would be something I guess I would initially jumps out to me. I don't know what the other thoughts are. When those numbers are so high, spreading them out further just magnifies that. I mean, if the numbers were single digits, sure, reward them. But when that top number gets close to 20, that's a concern I would see. So that's my support for 2.25, I guess, but could be convinced otherwise.
Okay, looking for a motion so we can have further discussion.
Making a motion, and then somebody could, but yeah, I'll
Okay.
make a motion for the 2.25.
Does that include also the
Yep.
GLP-1 change as well?
Yeah,
Yep,
it does.
including that, absolutely.
And I should clarify, operationally, we would still need to get this approved with Blue Cross Blue Shield to determine if we can just carve out the GLP-1s or if we need to carve out the weight loss medication class entirely. But either way, those drugs would still be ran through the Digby program. They'd still be covered.
So
So when we say GLP-1s, it could be all of the weight loss drug class that would move to not covered unless it's through Digby.
let's get a second, and then we'll address that in the discussion.
This is Desi, I would second for discussion.
Okay, so Stephanie brings up a valid point. I think, there could be potential if Blue Cross says no, then we're adding that 2% back on. Is that what I'm understanding?
Yeah, I don't think they'll say no. It's the structure of how it'll be done. There's an obesity class, and effectively because we've had other groups adopt the same thing where they just don't cover it within their manufacturer level. And it would kind of impact our messaging on the communication, just so that everybody's clear what's covered and what's not. But I think the important thing to say is we would have to get the communication structure right and the clarity from Blue Cross so that we administratively and operationally do it and the members understand. But it's clearly something they've done with other groups in terms of carving it out completely.
Keith has something in the chat discussion point. If we were looking at incentivizing moving plans, the 2.25% would be a better incentivization. Suppose. Okay. Other discussion. Further discussion. Hearing none. Let's do a roll call vote, Angie.
Yep. So Mike,
Yes.
Cole,
No.
Jenny,
Yes.
Desi,
Yes.
Keith, Kevin,
Yes.
Sonia,
Yes.
Chris,
Yes.
Steve.
Yes.
Okay. 8 yes, 1 no.
Okay, motion carries. We'll move on to item 4, which are the financials. Is Nora here to carry
I
this?
am sorry. I'm trying to share my screen and unmute myself and all the things. Can you see the financial statements?
Not yet.
Not yet. Oh, looks
Oh.
like it's starting, Nora.
There you go.
There it is.
Okay.
Yep.
We're gonna do two financials, one for the year end, one because Hunter has been busy and been doing some stuff with those, and then we'll give a February one so you have a more up-to-date idea where the financials are at. A couple of the things, one, I do have to still note that we don't have the IBNR adjustment yet. We're hoping it's not as gonna be as significant as some of the past years because we haven't added as many groups, but you just never know. I know Hunter is still waiting to get the information from Blue Cross Blue Shield to give to our actuary so they can complete that report. They like to have at least 2 months worth, so through February, and he has requested that and has not received it from Blue Cross Blue Shield. So these will still change based on that as well. But a couple of the major things to look at, one is we still obviously are very liquid between cash and CDs, so total cash equivalents are a little over 10 million at the end of the year. But two changes that he has made to those financials is the pharmacy rebate receivables. Again, some of those are on a 6-month lag, but the true-up ones are still on that 18-month lag. So Hunter has been basically using, and he's worked with the auditors in the past on this as well, trying to use like a rolling weighted average of what's been going on, what we've seen come in for those ones that are on those legs, and kind of use those percentages based on the premiums we have now and what we've had now to get with his estimate for that. So that is just under 2.6 million. The other new one is one he put on there this year that is new in October, I believe. Correct me if I'm wrong, Hunter. We received a stop loss experience refund in October for the previous year's one. So it's based on what the loss ratios are, the stop loss claims paid, what that ratio is. When we did the stop loss last year, it's based on what our premiums we pay in and then the loss ratios of those claims. And then we can be eligible to get some of that refunded where it caps at 20% of the premiums paid. So we didn't get one for the schools because their loss ratio was too high, but we did get one in October, I believe around 360,000. Again, I didn't memorize the exact number, but right around there that we got in October for the previous year on the January pools. And then looking at what 2025's numbers were for ending for the October pool, they're eligible. They won't get up to the minimum, but we should get some refunded for that. And then the January pool, again, looks like we should get up to that 20% of our stop loss premiums paid. So that new 725 receivable is that stop loss experience refund that we're calculating based on the 2025 numbers that we're getting for the 2025, but we probably won't end up seeing it until so the October one we'll see before, but it's usually about 9 months after the plan year end. So one we'll see around the June, July timeframe. One we'll probably first see around September, October for the January one. But we did put that on there because it is based on the previous year. And it definitely helps our year end looking a little bit better. But it does change from, where they talked about having the 101% loss ratio. It did take it down a little bit, but we still had a small net last year. But that, knowing that we have that stop loss experience refund coming definitely helps the bottom line for the 2025 year. You can see our liabilities continue to rise, and that again does not have any change to the IBNR reserve yet. So there's a chance that that will go up a couple $100,000 as well. But you can see the accounts payable is up there. The unearned premium is stuff that we received early that had it for January that we received early. That's for January's premium. So that's why that's up a little bit. But costs continue to rise for claims but overall, we're still sitting at right around 8 million, which is where it was close to last year. You'll see on the next page, we had a slight loss for the year, but we did have 112,000 in new member deposits in 2025 as well. So that's why it is up in the current year, even though we had a loss, but it's still consistent with last year for equity. If you look at the income statement, here's where you can see, this is December's actual. December was actually a decent month for us, but that again is because we booked that stop loss experience refund of the 725 and then booking the rebate revenue for not just the quarter of 25, but all of the true ups that Hunter was able to calculate and stuff. So that again, Those are estimates, but based on what we've seen, based on historical refunds and stuff of that nature, it's what we should receive for those years. But you can see for year to date, 2025, it was still, even with having those rebates and refunds, still up at a 98% loss ratio overall for claims. It was just a very heavy claim year when you look at it in that aspect. So that's one of the issues. Overall, you can see about $73,000 net loss for 2025. Again, that potentially will get a little bit higher once we get the IBNR reserve adjustment. I can't say that for sure. It might go down, but and we don't think it'd be a large swing this year, but that number probably won't stay the same once we get that number from the actuary. But overall, considering, I believe at the end of November, the last financial I gave you, we were like $1 million loss. It definitely looks better at year end than what we did at the end of November. So that's where that's at. So we're still sitting at a good spot for member surplus wise. We haven't eroded that at all. But again, the claims just, the figures kind of continue to rise there. But in February, we'll switch over to that one so you can get a more current picture. Our cash has, because we were at 10.1 in December, I believe. Yeah. So our cash has gone up, but our liabilities have also gone up. But we do, membership equity did go up a little bit. January is a rough start, but as far as ratios, but February got a little bit better. Again, you can see these accounts payable. That's the claims that we owe Blue Cross Blue Shield that we're first getting the invoice after the end of the month. So as far as liquid, we're still staying really liquid. We still have plenty of cash to be able to pay the claims, things of that nature, but everything is kind of being status quo. We're not building on surplus or anything of that nature right now. February, you can see we actually had a $500,000 net earnings, but we had a loss in January. So overall, year to date, we're looking at about 163,000 to the positive so far in 2026. Our loss ratio was good again in February, but we're still up at that 97% loss ratio year to date. And I know that I went over these fast, but I know I first kind of got in after the meeting was supposed to be done. But does anybody have any questions for me? And again, Hunter's the one who does all of the legwork as far as the estimates and how these things work, and working with Blue Cross Blue Shield and working with Brown & Brown to make sure we're getting everything booked. So I'm sure he would gladly ask any questions or answer any questions you have as well.
Nora or Hunter, this is Cole. So that 1% that we add on for these rates, where is that reflected at in here? I was trying to figure out, is that where that $200,000 change happened in 25?
Well, so we use that to try and build on the surplus. So what they're saying is using that, we're hoping that would give us a 1% build on the surplus. That's why we're increasing that rate so that it offsets more than just the claims coming in. But like last year, we didn't get to add anything really to surplus because of the high amount of claims and the claim loss ratio. So we're utilizing that to try and build our surplus and increasing it. So though that increase is just going up right up with the earned premium as well. So it's just offsetting the losses that are there. The reason we're doing it is because we're trying to build surplus. But in a year like 2025, where we had such significant claims and our loss ratio was so high, it didn't really actually build onto the reserve. Does that make sense?
Yeah, it's essentially a contingency to cover any unforeseen expenses. And if we don't
Yeah.
have expenses, it
Yes,
builds
and
up
then
the fund balance.
Yes. Like I said, last year we were able to 2024. If you look at the comparative going back here, we were, we had, a $3 million end up swing with that. Granted, we had the stop loss experience or the stop claim reimbursement was large last year with that one big claim, but we ended up being able to add on last year, but 2025, we did not have that same luck. If it makes you feel better, NDPHIT didn't have a great 2025 for claims either. Maybe it was just a year for really high claims. So let's hope 2026 will be a little bit better for us all.
All right. Do we have a motion to approve the financials?
So moved.
No, second.
Jenny with a second. Okay, any discussion? Any discussion? Any discussion? All those in favor signify by saying aye.
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 Any opposition? All right, I think we've ended our meeting. It looks like our next meeting is April 15th at 1 p.m. April 15th, 1 p.m. If there's nothing else, do we have a motion to adjourn the meeting?
So move.
We have a second.
Second.
Cool. All right, everybody says yes, good deal. Thanks for being here, everybody. Motion or meeting adjourned.
Thanks, everybody.
Thank you.
Thanks, everyone.